I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
This is a 77-year-old female, former light smoker with a history of stage 2B adenocarcinoma of the left lung, PD-L1 negative with no actionable mutations, status post robotic assisted left upper lobectomy and thoracic lymph node dissection. Pretty straightforward case here. What would be the systemic therapy you should treat this patient with? So let's just move on here. Patient developed a productive cough and had some shortness of breath, sought medical attention. Chest x-ray was deemed abnormal with the left upper lobe consolidation. She was diagnosed with a pneumonia and treated with antibiotics, but her symptoms did not improve. She has an ECOG performance status of 1. Her medical history is consistent with type 2 diabetes, renal insufficiency, and hypertension. Social history, she's a former smoker, just 4-pack year history, no alcohol use and no drug use, and family history, no lung cancer or other cancer. So Dr. Ginsberg, just want to walk us briefly through the imaging here.
So this is a typical spiculated nodule seen in the lung cancer, which in this case measures 1.4 centimeters, and the SUV was at 2.7. No other lymph nodes picked up FDG avidity, and there were no other metastases, and the MRI was also negative in this case.
Great. So 1.4 centimeter spiculated nodule in the left upper lobe, PET avid. As mentioned, no evidence of disease anywhere else. The patient has a biopsy, has a navigational bronchoscopy and a biopsy of the left upper lobe and mediastinal lymph node sampling. The pathology is consistent with a moderately differentiated adenocarcinoma. The mediastinal lymph nodes are negative on assessment. Dr. Lanuti, can you just comment on how you approach these patients? This seems like a pretty straightforward lesion here on the left upper lobe. Just your approach for these patients?
Yeah, upon presentation in a case like this, you can go on PET imaging for the start of staging. I don't often get MRI imaging for these early stage type lesions unless they're symptomatic. Getting a biopsy for confirmation is definitely a pathway people can take, and it's institutionally specific. Some people will go right to the operating room and do a diagnostic wedge of this, and then move on to an anatomic resection in the absence of mediastinal lymph node metastases. And then other institutions will want to get a confirmatory biopsy prior to proceeding to an operation. So if the lesion is deemed a lung neoplasm, then the approach should be minimally invasive and pending that the patient has adequate lung reserve. The only comment I'd have about this is that this lesion, I would probably do a superior division segmentectomy and spare the lingula. This is not a big lesion, and so I would do a lung sparing unless the histology showed me features that were very worrisome. And then during the case, as we always should do, is mediastinal lymph node sampling, if not lymphadenectomy, for adequate staging.
Okay. Before we get to the systemic therapy options post-operatively and the pathology, Dr. Curran, your thoughts on radiation options for these patients? Clearly some controversy on these T1 lesions, whether, what's better for these types of patients. I know that in the absence of a surgical option, certainly radiation is a consideration. How do you have conversations with patients about these types of lesions, and do you default to the surgery, the surgeon first for these fit patients, or is it a discussion to consider alternatives?
Yeah, I would view the standard of care for this patient to be surgery. If the patient had conditions which mitigated against surgery, then this might be a lesion you'd use a SBRT approach, but I've heard nothing about that in this case. So I don't see an indication for radiation as a competitive alternative to surgery, nor in the post-op setting. There have been a number of randomized trials that have tried to address the issue of resectable patients and whether SBRT is a competitive alternative to surgery. Most of those have failed to enroll because of probably the lack of equipoise and the difficulty for both physicians and patients. There is a ongoing study in the VA system known as VALOR, which is enrolling, I think has 100 plus patients in it. It does look like over a several year period in the VA setting, we might get an answer as to whether there could be equipoise between those options. But for right now, there is not.
Okay. Thank you, Dr. Kieran. So pathology, patient goes on to surgery. The pathology is consistent with a 2.2 centimeter invasive adenocarcinoma, moderately differentiated. Negative margins, but does have some lymphovascular invasion present. And a level 10 left hilar node is involved with cancer. The stage is a T1BN1. Moleculars are done that don't reveal any actionable mutations, and the PDL1 is negative. Some potential important information, maybe not. The patient's blood glucose is 284 and the creatinine is 1.2. And I believe this patient was 75 years of age or somewhere around there. So Dr. Govindan, how do you have conversations with patients about adjuvant treatment, and what would be your adjuvant treatment of choice for a patient like this?
Yeah. So what we know now is that multiple prospective clinical trials have clearly shown that post-operative adjuvant chemotherapy with platinum-based doublet improves the survival by about 5 to 10%. And the best benefit appears to come from the node-positive subgroup. So clearly, there is clear evidence that the adjuvant therapy is likely to extend the overall survival by at least 8 to 10% in this group of patients. So that's well defined. What is the role of molecular analysis? At the present time, there is no clear evidence that the PDL1 high, low, or non-expressor group do one way or the other with chemotherapy. And we do not have a proof at the moment that checkpoint blockade like pembrolizumab or nivolumab will play any role in this setting. There is an ongoing study that has been completed, the Alchemist nivolumab study. We hopefully will have some results soon. In the absence of that, I do not favor doing PDL1 testing on a regular basis. There is a recent evidence that EGFR mutant patients may derive improved progression-free survival or relapse-free survival with the adjuvant osimertinib after or instead of platinum-based chemotherapy. So that's the background data we have for systemic therapy. This individual is 77-year-old, it is reported renal insufficiency, but the creatinine was 1.2. Unless the muscle mass is extremely low or the creatinine has doubled over time, it's reasonable renal functions, I would presume. And the question is, what kind of a platinum would you give? 77-year-old with perhaps a borderline creatinine, even though we don't have prospective data for carboplatin-based chemotherapy regimen in the adjuvant setting, there are high-quality data, I would say, I would favor a carboplatin-containing regimen, and I may favor pemetrexed-based regimen, although pemetrexed can also worsen the renal insufficiency. But with the background diabetes, I don't know about the neuropathy here, but pemetrexed carboplatin is easier to take. I would give 4 cycles of pemetrexed and carboplatin, carefully watching for renal function, and also making sure that patients are instructed not to take Aleve or non-steroidal ibuprofen or naproxen, making sure that the renal insufficiency does not get worse. Those are the key things I would say in terms of practice points at the moment.
Very well summarized, and great points about the Aleve and the NSAIDs not to take given this borderline creatinine. So if the patient's creatinine was a little bit higher. I'm just curious. I think carboplatin, maybe you would still go with. What would you use in lieu of pemetrexed in the adjuvant setting? I get this question a lot. What can I use? There's still a chance for improving cure. What would be your platinum, not your platinum of choice, but what you would wed to the platinum?
So if you look at the prospective trials that looked at observation versus chemotherapy, the best tested regimens are cisplatin and vinorelbine. And basically, cisplatin and vinorelbine is the best tested regimen, both in the Canadian study and also in the European studies. But then the ECOG study that looked at the role of bevacizumab in the adjuvant setting allowed physicians to choose a variety of chemotherapy regimens that are histology appropriate, including paclitaxel, docetaxel, platinum-based regimen. And if I'm not mistaken, they all mandated that patients get cisplatin. And there did not appear to be any big difference between the subgroups. So I would say, in the absence of pemetrexed, taxanes are the ways to go, and paclitaxel carboplatin would be one. Docetaxel carboplatin tends to be very myelosuppressive, and a 77-year-old, that's not something quite trivial. So if I have to choose a non-pemetrexed regimen, I probably would choose paclitaxel carboplatin.
Great. Okay. Well summarized there. All very good points. So I think we can all agree this patient does warrant a discussion and a recommendation for adjuvant chemotherapy. In this case, based on the creatinine and the age, it seems like we would favor a carboplatin with pemetrexed for 4 cycles every 21 days. Is that a fair assessment, Dr. Govindon?
Yes, I think it's a good thing for us to remind our practitioners that when possible, we should use cisplatin in the adjuvant setting, because that's where we have the best data.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
So we have some exciting updates for early stage lung cancer or resectable lung cancer, specifically with a new approach with neoadjuvant chemo-IO. Remember, most patients up to now with surgically resectable lung cancer received the surgery first, followed by adjuvant chemotherapy, and now immunotherapy sequentially. But we've got a new treatment paradigm, and that treatment paradigm starts with Checkmate 816. This was a study evaluating patients with resectable stage 1B through 3A non-small cell lung cancer without harboring an EGFR or ALK rearrangement. And it did something very simple. It randomized patients to neoadjuvant chemo for 3 cycles versus neoadjuvant chemo plus nivolumab, immunotherapy. And then this was followed by surgery. The primary endpoint from this for this study was complete pathological response, which is basically 0 residual viable tumors in both primary tumor and sample lymph nodes. And other endpoints included major pathological response, which was less than 10% viable tumor cells in both primary tumor and sample lymph nodes. And if we look at the data, it was pretty compelling. The complete pathological response, meaning no tumor left over, in those patients who got chemo-IO was 24%, and the complete pathological response for the chemo arm alone was 2.2%. I think that's point one. Point two is, if you look at the early data cuts for event-free survival, the hazard ratio is 0.63. Now, this is not overall survival. This is event-free survival. We will, of course, see overall survival very soon. The third point I want to make about this study is that you are more likely to get a lobectomy in the chemo-IO arm versus the chemo arm alone. You are more likely to get a pneumonectomy, a surgery we like to avoid if you got chemotherapy versus chemo-IO. So better surgery, and also morbidity was no worse in the chemo-IO arm versus the chemo arm alone. So this is exciting. I think this is I think this is not only hypothesis generating, but paradigm shifting, and now FDA approved. The second study that builds on this is the NADIM-2 trial, once again, randomizing patients at this time only with stage 3A or 3B. Pretty remarkable. This is a stage we never thought surgery was in the calculus for. Randomized to neoadjuvant carboplatin versus carboplatin nivolumab for 3 cycles. Again, asking the question, does the addition of immunotherapy do anything to chemo versus chemo alone in the neoadjuvant setting? And similar, what we saw, similar to 816, complete pathological response. This is for 3A and 3B, resectable. And again, we don't normally operate on 3B. Complete pathological response of 37% versus only 7% in the chemo arm. So chemo IO arm, complete pathological response of 37%. Once again, no additional challenges with surgery. And we see early data cuts from this study that was presented at World Lung showing an overall survival advantage. So the point I want to make is I think it's really important to consider neoadjuvant chemo IO for our resectable patients. I also want to make the point that not all patients with 3A or 3B are resectable. So this is not for everybody, but I think it's a consideration for our 3As if the surgeon thinks that they're resectable. So this is critical to think about. This really, every case that's 3A or surgically resectable should be presented in tumor boards. This takes a tremendous amount of coordination from the surgeon, the medical oncologist, the radiation oncologist, the pathologist. So it's an exciting time, and this is going to be a paradigm shift, but it's going to take a lot of coordination on behalf of the doctors taking care of the patient.